For 2 days, pediatric ethicists, researchers, and medical experts from the United States and around the world gathered at the Bell Harbor International Conference Center in Seattle, Washington, to discuss the difficult and challenging ethical issues surrounding prenatal and neonatal care.
In neonatology, there are more and more ethical dilemmas as we push the lower limit of viability.
The issues of how parents interact with neonatologists to make decisions regarding their babies are very important to my work.
The Truman Katz Center for Pediatric Bioethics at Seattle Children's Hospital presents its 6th annual conference, Tiny Babies, Large Questions, Ethical Issues in Prenatal and Neonatal Care. The Truman Katz Center is the nation's first center dedicated solely to the study of ethics relating to research and healthcare for children.
We're going to change our focus a little bit from a more U.S. context to a global context and talk about many of the same issues we've been discussing, but this time in the context of the entire world and limited resources and so on. And I think we've got some great talks planned, as well as the second half of the morning, which features 6 of our abstract presenters. This has actually become one of our favorite parts of the program. We have solicited abstracts from people who are interested. This year we had somewhere between 30 and 40 of those submitted, and many of you got a chance to see posters from some of those, and the last part of the morning we'll get a chance to hear from 6 of those, and that, as I mentioned, has been a real highlight of our program. The one thing I was asked to remind people of before we launch into this morning's program is even if you're not interested in CME credits, please sign in again for the second day. There's sign-ups out at the registration desk, and we would like to track who's here. And we can't give CME credits for those who need them unless we have your signature on that sheet. So at the break, if you haven't already signed in, please do that. All right, I'm going to introduce Craig Rubens. Craig is going to moderate the first half of the morning session. Craig has been a colleague of mine for 20 years. He's a professor at the University of Washington in the Division of Infectious Disease, and has devoted most of his career to exploring mechanisms of infection that occurred during pregnancy and in the early newborn period. And his work has been revolutionary and led to some insights into the potential development of some new vaccines. Most recently, Craig has devoted a lot of his time to co-founding and now executive directoring the Global Alliance to Prevent Prematurity and Stillbirth, or the GAPS. And the GAPS program is an initiative at Children's Hospital partnering with the Gates Foundation that is designed to create innovative research and interventions that will hopefully improve maternal, newborn, and child health outcomes. So Craig is the ideal person to help us moderate this morning's session, and if you'd please join me in welcoming Craig.
Good morning, everybody. I can tell by watching people walk in this morning that the sunshine has put a little pep in all of our steps. I just want to tell all of the folks that come from out of town that this is the weather we have every day in Seattle. No comments from the locals? Okay, very good. Well, I'm really honored to be a part of this and to moderate today. For a variety of different reasons. The GAPS effort, Global Alliance to Prevent Prematurity and Stillbirth, was a natural outgrowth of some of the work that I was doing, but really reflected also the vision of Seattle Children's Hospital and the faculty and staff there in recognizing how important preterm birth was, even in our backyard and in our local community. And I think when we start using the word like global, it means something a little different than maybe what all of you have been thinking about. It's been my experience now over the last 3 or 4 years in working on this topic on a broader level, that international in the United States really means things that are occurring outside of its own borders. And some of us have now used the word global to mean things that even happen here in our own backyard. And as you heard yesterday, that the problem of premature birth and even stillbirth are big problems even in the United States, and until recently have actually been on the rise for the last 30 years. On an international level, we're just beginning, and a level beyond the borders of the United States, we're now beginning to understand the magnitude of the problem. And what you're going to hear about this morning is some of those numbers, which are truly staggering, and how much we haven't done to try and meet the burden of disease around the globe. When GAP started in 2007, what really launched it was a landscape review and analysis that was commissioned by the Gates Foundation to really look at what was going on in the world's community. And it was an analysis that encompassed what we knew and didn't know, even upstream in the basic sciences, all the way to what needed to be done in terms of better health services, strengthening and delivery of interventions, and what wasn't being done. So it was very comprehensive, and at the very outset, one of the things that struck us was the fact that there were issues beyond what scientists themselves could even think about, that were really ethical, social justice issues. And to our great luck, Dr. Wilfon, Dr. Kelley, and others in our bioethics department came to our rescue and early on began working with us very closely to show us how we could consider some of the ethical, social justice, gender inequality issues that really pervaded everything that we were looking at, even in the upstream sciences. So, in a way, we began working with our ethics partners and colleagues, and even the science of ethics in this area at very early stages. And to my surprise, at our conference last year, Dr. Dan Wickler, who attended, basically came up to me and he shocked me. He said, you know, this was the first time ethics was actually drawn in early to a major topic that hasn't been dealt with in global health. And so we felt honored at the fact that we'd actually serendipitously fell into bringing our ethics colleagues into the discussion much earlier. Now, as a moderator and as a guy over 50, I will tell you that one of the greatest things you can have asked of you is to moderate sessions where you get to introduce the up-and-coming generation and stars that are thought leaders in the field. So today, we're starting a little bit early, and so what I would like to do is to first introduce two speakers that are going to play a tag team role in presenting their discussions today. Dr. Maneesh Batra is an assistant professor of pediatrics in the Division of Neonatology, an adjunct assistant professor of global health, and the associate director of pediatric residency program at the University of Washington School of Medicine. Now, all the ones I'm going to introduce today have titles like that, and I don't know how they get it on a business card or a letterhead. He is a core investigator for the GAPS program and a member of the neonatal morbidity team of the Child Health Epidemiology Research Group called CHIRG, and his international clinical experiences include works in Harare, Zimbabwe, Managua, Nicaragua, and Kyoko and Uganda. And for the past 5 years, he's been involved with the medical direction of a rural special care baby nursery. Now, if that's not enough, his research work is addressing pregnancy outcomes in Washington State, hence the true global nature of our efforts, and works with local physicians in Bangladesh to validate neurodevelopmental screening instruments for community health workers to identify infants and children with impairments. Now, on the flip side, if you will, is Dr. Maureen Kelly. She's an assistant professor in the Department of Pediatrics in the Division of Bioethics at the University of Washington and a scholar in the Truman Katz Center for Pediatric Bioethics at Seattle Children's Research Institute. She holds adjunct appointments in the Departments of Bioethics and Humanities and the Department of Philosophy. She's on the affiliated faculty at the University of Washington Center for Human Rights and the program on Values and Society in the Department of Philosophy. She chaired and continues to chair our Ethics and Social Justice Working Group for the GAPS Initiative. And she earned her PhD in philosophy at Rice University and completed her clinical bioethics training at Baylor in Texas. She's held faculty appointments there and at the University of Alabama Sparkman Center for Global Health. Her research now centers on the ethical dilemmas in maternal and child global health and international research ethics. And she's helped develop research ethics programs with special attention to vulnerable subjects in Siberia, Zambia, and Fiji. Her current research focuses on addressing the dilemmas of care for orphans and other children and teens living without families. So the title of their joint presentation today is Better Early Than Never: Ethical Dilemmas in Preterm Birth and Survival in Resource-Poor Settings. So with that, I'd like to start by inviting our speakers up to the stage. Dr. Batra.
I'm a neonatologist, and I care for babies and their families here in Seattle at the University of Washington Medical Center and Seattle Children's Hospital. In 2003, I visited Chiwoko Hospital for the first time, shortly after the opening of a special care baby nursery there. And I've been involved with the development of that program ever since. After hearing the view both from above and from below, we'll dive into a closer look at the ethical issues that surround us as we care for newborns in resource-limited settings. So what are the stakes we're talking about that Craig alluded to, and what's the magnitude of the problem? The numbers, this bird's eye view, definitely tell one side of the story. Each year, 10 million children under the age of 5 die. Of those, 7 million are less than 1 year of age. Of those, 4 million are newborns. This equates to about 10,000 newborns who die each day. In all, just less than half, a third to half of all under 5 mortality is attributable to newborn mortality. Of those 4 million newborns who perish, half of them die within the first 24 hours of life. 99% of these deaths occur in low and middle income countries. And as I'll show you in a minute, 2/3 of these deaths occur in just 10 countries. Indeed, the magnitude of childhood mortality globally is staggering. And overall, improving childhood mortality has been a focus of much attention from the global community for a very long time. In September of 2000, world leaders came together at United Nations headquarters in New York to adopt the United Nations Millennium Declaration, committing their nations to a new global partnership to reduce extreme poverty and setting out a series of time-bound targets with a deadline of 2015. These 8 Millennium Development Goals, which are shown here, range from reducing extreme poverty in half to halting the spread of HIV/AIDS and providing universal primary education, all by the year 2015. Though they form a blueprint agreed to by all the world's countries and have truly galvanized unprecedented efforts to meet the needs of the world's poorest, they don't define how to achieve this change, nor do they identify resources for motivating change. Rather, they set out targets for the rest of us to aim for. With respect to child mortality, the target goal is to reduce mortality by 2/3, starting with the numbers in 1990, by 2015. Though MDG 4 focuses on childhood mortality and MDG 5 focuses on maternal health, and as I've already discussed with you, a disproportionate number of childhood deaths actually are attributable to newborns, it's a bit of a bummer, if you will, that fetal and neonatal health weren't explicitly called out in the agenda. Though maternal, fetal, neonatal, and child outcomes are all inextricably linked, fetal and neonatal mortality remain invisible, even in the United Nations Declaration. So how are we doing with making progress towards achieving MDG 4? In 1990, where this started, the under 5 mortality rate globally was 100 deaths per 1,000 live births per year. Therefore, a reduction of 2/3 by 2015, as specified by MDG 4, would put a target at 35 per 1,000. The dark line shows progress made between 1990 and 2004, demonstrating that at that time, we were on a course to achieve MDG 4 30 years late, doubling the amount of time initially specified for MDG 4. So much attention since that time is focused on how do we move the slope of that dashed line, which is our current rate of progress, to that of the blue line. When you take a little closer look at that last graph, as we have here, the top line on this graph actually reflects the slope of the line you saw previously. On the x-axis, we have 3 time points, 2000, 2004, and 2008, and focus on the bars for the least developed countries. The entire bar shows childhood mortality, and as you move down each bar, it's divided into childhood mortality, post-neonatal mortality, late neonatal mortality, and early neonatal mortality shown on the bottom of each bar in the darkest color. If you follow the dotted line, it becomes clear from looking at this graph that the improvements made in childhood mortality were the result of improvements in post-neonatal mortality alone, and that really we haven't made any difference at all in neonatal mortality. It becomes clear then, as experts agree, that in order to get back on track to achieving MDG4, reductions in neonatal mortality are critical. So how do we do this? Well, first you have to know where to go. Turns out we know exactly where to go. As I mentioned before, 2/3 of the neonatal deaths in the world happen in these 10 countries in sub-Saharan Africa and South Asia. And in fact, 1/4 of all neonatal deaths in the world happen in just one country, in India. And Dr. Saeed will be talking about his efforts in India in a subsequent talk. So what makes neonates so susceptible? This won't be news to many of you in the audience, but there are both innate factors and environmental factors that contribute. The transition from fetal life to neonatal life is a challenge indeed, with several important time-sensitive processes that need to occur in a very coordinated fashion. In that transition from fetus to newborn, the newborn has to establish its breathing, change its circulation, begin to maintain its body temperature, and begin feeding, and protect itself from the environment. This all happens in a few seconds. A second challenge is that identifying neonates who are ill is not easy. They simply don't have ways to show us that they're sick until it's very late. And finally, since the majority of births happen at home in the world, and half of all neonatal deaths happen in the first 24 hours of life, even with early recognition, access to intervention is a significant challenge. So what are the causes of deaths? 1/3 of all neonatal deaths are attributable to infections. I'm going to repeat that. 1/3 of all neonatal deaths in the world are attributable to infections. It's appalling, really, if you think about it, that we have effective treatment for most infections, and if we initiate them early enough. Another approximately 1/3 are due to preterm birth, and a very large proportion are still due to birth asphyxia. Analogous to developed countries, the risk of death is highest for our smallest babies. In developing country settings, 60 to 80% of all neonatal deaths in the world occur in babies with a birth weight of less than 2,500 grams, the majority of which are preterm babies. Furthermore, in these resource-limited settings, the risk of early death in babies born with a birth weight between 1,500 and 25 grams is 6 times greater than their normal birth weight counterparts. And for those born less than 1,500 grams, the risk of death is 100 times greater than their normal birth weight counterparts. So this all sounds probably pretty daunting. So what will it take to make a difference? What are the major barriers? Well, you're going to hear about a lot of those throughout today's talks. It turns out, however, as you'll see now and later, that from a financial standpoint, it's actually fairly cheap. It's estimated that 3 million newborn deaths could be prevented with low-cost, low-tech interventions which exist already. Estimated that about $1 per inhabitant per year could reduce 3/4 of these newborn deaths. For example, the marginal cost of adding neonatal resuscitation training and equipment for midwives, something that we take for granted, would cost less than 2 cents per capita per year. The reason this is the case is most of these deaths could be prevented with simple interventions, such as improved thermoregulation, breastfeeding, kangaroo maternal care, early treatment of infections, and only a very small minority of patients will require costly intensive care. So why haven't we made a difference? Well, as I'm alluding to, you'll hear throughout the day why money isn't enough to make a difference. That was the view from above. Those are the numbers. That's what the experts say. I'm going to try something a little different to convey the view from below now. The goal in presenting this case example is to provide some insight into how thousands of parents, families, and providers experience the disease burden on the ground. For the purpose of the discussion, I'll present a case from a rural hospital in central Uganda. As I mentioned, I've been visiting this hospital now for the last 7 years, and the excerpt I'll share with you is from a trip from January of this year, right after the opening of a new Nicu there. This was after years of process improvements and improvements in outcomes for the hospitalized babies there. Uganda is a beautiful landlocked country in East Africa with a very sordid political history. It's a developing country that's poor. It's a very rural population with a high fertility rate. The life expectancy is 42 years, and the government spends about $5 per capita per year on healthcare. The case example I'll give you could be extrapolated to numerous settings. This is just one example. The district that the hospital is in the Luero district, which has a population of 500,000. It's right there, just north of the capital, not far from the capital. The majority of that population is rural. Access to healthcare services poor, even by Ugandan standards, and child mortality is in the higher band in the country. In fact, if you look at the under 5 mortality rate, and these numbers are from 2005, of 150 deaths per 1,000 live births, I'll just remind you that that's higher than the global neonatal mortality rate in 1990 of 100 per 1,000 live births. This is the gate to the hospital. So as you can imagine, most patients arrive by foot, boda, which is a motorcycle taxi, or a matatu, a shared motorcycle or a shared van minibus. Most people in this region live in extended family clans, and this is a very common home. It's made of earth with a grass roof, a jerry can out front for collecting water from the well. You can see all the banana trees in the background. It's a very beautiful and lush landscape, and this is a subsistence agriculture economy. The cooking area would be off to the left, and the latrine area would be off to the right. This is a view inside the pediatric ward. There's limited electricity, lab support, medications, blood products, and healthcare workers. For the entire 200 to 300 bed hospital, there are 4 to 7 Ugandan doctors at any time. They do everything from antenatal care to C-sections, HIV care to colostomies, malnutrition treatment to caring for babies in the NICU. On this particular peds ward, there's room for about 70 to 80 kids. You can see one nurse in the middle of the screen there for the entire ward. And between the cots, you can see family members and their belongings. Like in many settings like this, a family member is necessary and an integral part of the hospital team to care for the patient in the hospital. They collect the water from the well, they make the food for the patient, they administer medications, etc. They have to leave the rest of their family at home in order to care for their loved one in the hospital. That one nurse couldn't care for all these patients, so this is really critical to moving the care forward in the hospital. This is a view inside the original NICU. I'll show you a view inside the new NICU in a moment. You can see that it's crowded with a collection of donated equipment in various stages of repair. And just like the peds ward, you see the mums are doing a lot of the work. They're scattered all around the outside with their babies along the outer part of the picture there. They're washing linens, they're changing diapers, cloth diapers, they're doing the feedings, they're doing kangaroo care to keep the baby warm. And they're even doing gavage feedings, as this mom is doing here on her tiny baby in an incubator. So now I'll read you an excerpt from my journal. Day 1, another beautiful morning in Chiwoko. Nescafe in my hand, birds chirping, and kids playing outside. It's good to be back. Over the last 7 years, I've made some good friends here. But every time I visit and return home, I leave a piece of me here and bring back something new with me. It's no wonder that this is where I was inspired to pursue caring for babies in the first place. Over these years, it's been amazing to see the staff care for these babies. As an outsider, an opinionated one at that, at times I'm truly burdened at the thought of these babies dying somewhat needlessly. Is it really no one's fault? How should one act in the face of scarcity, knowing there's a better standard to be had if only circumstances were different for these little ones? As I walked into this brand new NICU, 33-week triplets arrived. Since they weighed around 1.5 kilos each, they were at very high risk of dying. However, it was absolutely incredible to see the way they were tucked in by the skilled team. Within an hour of delivery, they were in incubators with IVs, having their hypoglycemia corrected, and 2 out of 3 were receiving appropriate oxygen therapy. It was amazing to see these 3 babies tucked in so calmly, all at once in the NICU here. This was in stark contrast to the first admissions I witnessed years ago here. Now the nurses knew exactly what to do and how to do it. These were spontaneous triplets born to this young mom who already had 3 older children. She looked tired when she walked into the NICU 1 hour, yes, 1 hour after delivering the trio. But if I hadn't known prior, there was no way to know she had just delivered 3 babies. Mom was shy, as many of the moms seem to be, with all the staff, but certainly with me, a somewhat loud Mzungu who tends to make too much eye contact for their comfort. But this mom opened up a bit faster. She seemed happy, truly happy and proud of her 2 boys and 1 girl. From the outset, baby boy C, triplet 3, who's shown here, didn't look as strong as his siblings. Here, in the past, the trio would likely have been in the same bed or isolette together. But now that this NICU was so fortuitous with so much equipment, they were separated. The thought did cross my mind briefly on this day that if baby C wasn't going to make it, would he ever feel his siblings close by? Though he was struggling, he was by no means tiring, so the thought entered and left my mind. Next slide. Day 3. Triplet C continues to struggle. He's having desaturation episodes that require some resuscitation. It's really great that he's on continuous oximetry, for if he hadn't been, he likely would have arrested before anyone noticed he was turning blue. I guess oximetry is a bit of a double-edged sword here, in that before they had it, they relied on clinical exam, and now they stare at the number on the screen. Furthermore, now that there's oximetry, these little babies are resuscitated from deep desaturation episodes, whereas previously they would have passed. Who knows what's happening to their organs and their brain with these recurrent resuscitations? A double-edged sword indeed. The mom's around all the time. She's sleeping outside under a tree with all the moms, and they seem to be developing their own unofficial mentoring program, with the more veteran moms chaperoning the new moms through the throes of washing breasts, expressing breast milk, eating and drinking, holding back tears, maintaining hope, and learning to live away from family and support with a baby in a box. Maternal nutrition is a huge issue here. The moms seem to be used to sacrificing their health for their children and are in the habit of frequently foregoing eating so that their children can have some food at home. The burden on the families is huge. The financial piece alone is massive, as many of the families have no money to speak of as they live in a subsistence culture. Some have sold land or other belongings to pay for their babies in the hospital. The mom of the trio has left her 3 children behind and her husband, who works, in a home with no other adults. Her husband will come next weekend to make payment, but until then, she's alone with her babies in these boxes. She's happy. She sees that A and B are pink and getting better. She trusts that everything will be okay for C, even though I'm becoming a bit more doubtful. If we had CPAP, this would have been an easy save. If mom had received antenatal steroids, perhaps we wouldn't have needed the CPAP. Without both, surfactant therapy could probably reverse the process. Without these valuable yet expensive prevention and treatment modalities, I'm witness to the natural history of respiratory distress syndrome in exquisite and gruesome detail with this little guy. He's beginning to lose his lung volumes, and because we can't nourish him and he's working so hard, he's becoming weak. He's turning grayish. His bones are showing through his skin. I've seen babies like this turn around here, but I'm afraid this little guy won't. I asked Sister Christine, the nurse in charge, if she thinks that mom knows that C is sick. She tells me that she's told her such and that mom is praying. The mom's been holding the baby daily until this morning when it seemed the baby was too weak. I look over at her and she's holding the baby's hand through the hole in the plexiglass calmly. Day 4. Triplet C hasn't been able to turn a corner. He looks ashen, emaciated, and uncomfortable. It's very sad. I wish we could ventilate him. I asked the mom if Dad was coming soon. She said he wasn't supposed to come until the weekend. Without telling her why, Sister Christine mentioned to Mom that Dad should come sooner. I think Mom knows what's happening. The staff here are becoming very skilled at managing the little ones with the resources they have here. So much so that it seems now they are facing many of the same dilemmas we face with respect to viability and morality in pursuing aggressive care. What about suffering here in the name of trying to save more babies? What will the families think if we begin to offer non-resuscitation? Day 5, Triplet C is struggling to live. In contrast with the past, when I would have noticed the staff immediately begin CPR, they've become more skilled, and I think they know what's happening, and they've fetched the mom. We spoke with her explaining the lungs were too immature to sustain life. Sister Rose and Christine were with me, and I asked if the mom would like to hold the baby, and she said yes. She held the baby for a while, and during that time, the saturations did come up, and we waited with bated breaths. Within a few hours, the baby passed. I cried. I watched the little one's hands and feet and eyes and mouth as he died. If Mom had received antenatal care and had received antenatal steroids when she presented, could this have been prevented? I thought of my own son. Fortunately, the father was able to arrive before the baby passed and see the baby, although according to the staff, he was less brave and didn't want to hold the baby. Christine sort of urged him to. The whole while he was holding and the baby struggling, he actually didn't look at the baby. He looked at Christine and was asking about arrangements and such for after the baby's passing. It struck me that this papa was really doing the best he could, and this was his response. He was trying to help his family survive. Who's caring for their other kids now? In this community, back transporting remains after passing is a huge challenge and expense. The matatu drivers won't let you on with remains, and a boda driver won't let you carry a dead body. I believe that the loss of a child in Uganda is no different than in Seattle with respect to the impact on families. While the father was worried about how to handle the hospital fees and getting their baby back home, Mom was wailing silently. The way we all show pain and fear is different. As I look back at the 2 surviving twins now co-bedding in the same isolette, glowing under the blue phototherapy lights, I wonder how the 2 remaining babies will do and what they will hear later about their brother who didn't make it. At this point, I'd like to turn it over to Maureen, who will discuss the ethical issues facing families and providers in settings like the one I described in Chwoko, including reflections on her ongoing work with women in Zambia. Thanks.
And so what I'd like to do in following up on Maneesh's very moving account of the NICU in Uganda is to get you all to think about some of the ethical challenges that emerge in developing countries, but also in middle-income countries, and here I'd argue in low-resource settings where you're highly constrained by the resources at hand. And a lot of these dilemmas, I think, will be familiar to you, to those of you in this room, even if you've only ever worked in the U.S. or Canada or Texas, but maybe not. But I think what's unique and what I'd like to highlight is that there are a whole host of dilemmas that are needless. So you've seen from Maneesh, there are senseless and needless maternal and child deaths that are happening throughout the world. And I'd like to argue that some of the just heartbreaking trade-offs that these parents are facing, that women are facing, are also needless. And so I'm going to focus on 2 types of dilemmas. I'm going to focus on dilemmas that are generated by the resource constraints of living in poverty, and then those that are a function of gender inequality. And while some of the aspects of those trade-offs might look different or be somewhat unusual and something we don't face here, the starting point is a universal one, I think, in looking at neonatal survival and looking at maternal well-being and survival. And so the starting point to keep in mind is that I think the joy of a healthy newborn is universal. And so going back to the very moving story from yesterday from Annie and James, I think that story and the story of the parents wrestling with the loss of baby C and the survival of his siblings, I think is a universal experience. And sadly, the anguish is also shared worldwide. And so I think that should be the starting point in thinking about how to move forward in helping address and think about the ethical dilemmas that these families face. But what's different, I'd like to argue, is that the anguish of loss, again, so much of it is needless. You saw the statistics from Maneesh of just how preventable a lot of these neonatal deaths are. And so that's the sense, I think, in which there's a new gray zone that we have to tackle and that those of you in the room could partner in tackling. There's no doubt that poverty fuels hard choices and hard moral choices. But again, I think that these are issues that really could be prevented. So I'm going to start by looking at some of the dilemmas and difficult choices or hard choices that are generated by a life in poverty. And one thing to think about is just how mundane some of these are. I mean, one of the things Maneesh and I have both found is that we think of these as dilemmas because we have a foot in both worlds, but the moms we're working with don't. They don't think of it as a dilemma. This is just sort of life as usual. This is not life at the margins. Having to choose between a bus ticket to Lusaka to get to the high-risk OB clinic versus staying at home and working another day in the fields or simply being able to watch your younger children is a trade-off, and I'd like to say these are the sort of Sophie's choices that we're seeing around the world, again, sort of quietly, right? It doesn't warrant a movie or a book by William Styron, but it's happening every day. And one of the things that the parents face is trade-offs between siblings, trade-offs between the well-being of their families. In our study in Lusaka, one of the most common reasons why women won't make the effort to go into a facility where her birth would be much safer for her and her child is that it's simply that bus ticket is daunting. It would mean 3 months of meals for that family, whereas if they use the midwife in the village, they can trade some food. They can give the midwife some food, and she can then care for the family. And so the mothers sort of know that it's high barrier economically for that family to get into the city. And going back to Maneesh's case, when dad came in to pay the bill for the hospital and mom had been in Chiwoko caring for the triplets, who was at home? Who was there watching the children? And so these trade-offs are played out on a daily basis. So that when a mom faces complications in pregnancy and she's made the decision, understandably, to be at home, this can sometimes mean the life or death of that particular child and also her own health in the high-risk pregnancy. And one of the things I think we have to think about from an ethical point of view, and you heard this echoed in Maneesh's comments, is the what if. Right? The what ifs can be paralyzing. What if we had CPAP? Right? This would have been an easy save. What if mom had received steroids? What if he had surfactant? And I think the toughest what if is what if the baby had survived? And it's not just someone like Maneesh asking the what if and sort of wrestling with if only, but it's also the parents, it's the Ugandan physicians in that unit who are quite aware of what might be done. And I think that what if can have a lot of power for change, right? But in the moment, it can cause paralysis to sort of sit and wonder and wrestle and anguish over not having CPAP, not having surfactant. So one of the things I'd like to talk about is how we think about facing those types of dilemmas where you are aware of what the standard of care is, of what's possible, and how you ought to move forward with that particular family, but then also at the higher level in terms of investment in that NICU at the country level, and then at the funding level with organizations that are interested in trying to address the more systematic problems. And I think that this is a broader challenge in global health. And the way I characterize this is as a problem in compromise, really. And the idea is, I think once you know what's possible, that there is a sense in which, once you're aware of what we can do for families, for mothers, for these babies, if only things were different, it does doing something less than, I do think, is a compromise on what's possible, on what we're capable of doing. And Dan Wickler has argued quite vehemently with me that I shouldn't characterize this as compromise, right? That as long as you are doing the best with what you have on hand, you're acting morally, you're acting rightly, and you're acting justly. And I'd like to argue that it's really important that we keep in mind that it is a compromise on what's possible, that moral psychology of aiming for more once we know we can do more is, I think, a really important way to think about these problems. And one of the reasons is actually a practical one, the inertia of settling for less. This is one of the current tents right now in Haiti, and I think we'll probably be seeing this tent for quite a while as long as it stands through the rainy season. A lot of the refugee medical camps become permanent medical facilities for as long as the canvas will stand it. And so there's a sense in which compromise or substandard or emergency measures, interim measures, take hold and they become the status quo. They become part of the woodwork. They become what we're used to seeing. And in the inertia of just trying to make do with what's right in front of you, sometimes we forget about ultimately what we'd like to be aiming for these people in these settings. And just to give you an example from maternal newborn health, this is a really heated example in trying to decide where your investment ought to go. At dinner last night, we were talking about the Albert Schweitzer Hospital in central Haiti, and they're wrestling with, should we invest more in our surgical operating room and in our facilities, or should we try better to improve some of the lower tech aspects of care, the community outreach, for example, hire an additional community health worker? Should we take some of that budget and tilt it toward antibiotics? These kinds of questions, I think, reflect this challenge in thinking about how do you aim higher while making these very practical decisions about what you need right in front of you. So in maternal health, the battle is the majority of women in the world are giving birth at home. And so it would seem to be an effective use of resources to train midwives, right, to train traditional birth attendants, because this is where the women are going to give birth, to do sophisticated procedures to deal with a breach, and controversially, some have argued, train them to do C-sections. Right? But ideally what we want is we want to get those women to safe facilities where they can have emergency obstetric care if needed, safe obstetric care. That's the ideal, and that's what we want. So here's the dilemma, practically speaking. We invest in a program for training midwives in the interim. What happens in terms of the inertia of that public health program? We've now trained a generation of midwives. The women get used to this practice, and then trying to get over that to convince them to go into the hospital and trying to find the funds and get those funds diverted for building the safe maternal clinic or OB clinic can be really a difficult barrier to surmount just in terms of the political inertia in those programs. And so I want to argue that I think if you think about this as a compromise on what's possible, the training midwives program, you realize that you need to do both and that both need to move forward. But I think unless you think of one as interim and one as ideal to work toward, it's too easy to sort of acquiesce in the way things have always been done, or the easiest or the path to least resistance. But I think it's also problematic to take a sort of hard idealist stance and say we should abolish or not even pursue the training of midwives, because if we do, we're going to undercut the political will for that high-tech OB unit, right? So you see the quandary. So, and I think as you think about which way to go, there are a number of points that I think can be helpful in thinking about a kind of ethical strategy, both for individuals who are working in these areas, including those who are there, trained there, live in the country, but I think also those who are partnering with resources and with large organizations who might actually be able to tackle some of the root causes. The sort of first and I think fundamental challenge to overcome is what Paul Farmer has called the Luddite trap. It's really easy when you look at these problems and you look at neonatal deaths or maternal mortality to think, well, if the root cause is poverty, why don't we tend to poverty? Why don't we focus on the systematic political changes that need to be made rather than scaling up a surfactant program or improving the Nicu or improving the OB delivery? And he says there's a real risk in thinking that way and also thinking sort of low tech is best in these environments, right? And so it's similar to the compromise trap, is that you get trapped into the mindset of, well, you know, this is the best we can do. And I think what's so great about Maneesh's example and about what they're doing in Chiwoko is you see simultaneous movement on both fronts, right? You see the use of fairly high-tech NICU equipment, and you also see kangaroo care hand in hand, and you also see community outreach and working with midwives. So that's, I think, a way in which to avoid the Luddite trap. You can leapfrog with technology, and I think there are a lot of organizations that have shown that to be quite an effective approach. The other thing is to engage the women, the families that are wrestling with, and ask them what they need, how they think about these difficult choices. And I think this is something we can talk about in the discussion a bit later. But the moral choices that these parents are wrestling with in life and death are very private in a way in which I think we're not used to. We think of, there's not a legal infrastructure that looks at resuscitation guidelines or withdrawal of care. These are quiet decisions that are being made by families and by the caregivers on these units or in the field or in the home. And it's this very personal, moral, spiritual sphere, and it's not something that's observed and teased out, and there are no appeals to principles. So I think this engagement piece is so critical in terms of beginning to think about this gray zone, the new gray zone in global health, and how to think about the moral dilemmas being faced by parents and women in this area. The other thing is, I think, more practical, and that is oftentimes the left hand doesn't know what the right hand is doing. And so if you're the right hand, please know what the left hand is doing. There's a lot of goodwill. There are a lot of excellent, excellent programs and people in the field, and yet they don't often communicate. And so I think, and they often don't communicate with those who are there on the ground and have been for 10 years. And new programs come in, they're very focused on a specific particular outcome. And so partnership is really critical. The other thing I think you can do when you're facing these dilemmas and you're facing severe constraints on resources is to advocate. You do the best with what you have, and then when you walk away, you advocate for more. And so that's something in the training program when we send residents over that we really emphasize because I think they feel disempowered and frustrated, and they know what is possible in neonatal care and good maternal care, and they come back absolutely distraught and wanting to do more. And I think there's a lot you can do as an advocate. So I think you end up wearing a lot of hats when you work in these settings. It's also important to think about what are the unintended or harmful consequences of our interventions as we do scale up, as we resist the Luddite trap and we scale up. The example of oximetry is a good example. Do we really know, and have we thought about the implications of resuscitating these babies that have gone through desaturation episodes? Have we thought about the impact on those families in contexts where managing that morbidity is challenging? But nor do we want to assume that they're not able to handle children with disabilities, right? So I mean, I simply think it's an empirical, important, critical empirical question of what is the downstream effect as we introduce these technologies in NICUs and in the OB setting. So I also want to focus on this sort of second, I think, really significant contributor to the ethical challenges and dilemmas in settings like this, and those are the dilemmas fueled by gender inequality. If you just look at the clustering of, around birth, just the event of birth, and you see child death, newborn death, stillbirths, and maternal deaths, you realize that birth throughout the world is still unbelievably risky for women, for babies. And again, these are needless deaths. These are deaths that could be prevented by treating an infection, by addressing asphyxia. I mean, these are These are causes that are highly, highly preventable. And I think it's really critical in thinking about neonatal survival. There's so much focus on child survival, and this is a prime example at the policy level of the right hand not knowing what the left hand is doing, is that sometimes I think those focused on neonatal survival are not focusing at the experience of the woman and the broader contributing factors to maternal health and child health and the way in which they're intimately linked. And one example, I think, of this is the silent suffering of stillbirth, and that's one aspect of the study that we're looking into. And it's not only devastating for the women, and again, this is a universal phenomenon across many, many cultures. It's a very silent, sort of devastating thing for many women. And one of the things that we've found in talking to women, again, this is a small group, and there are a lot of cultural norms that may not be shared outside, but it's the way in which they wrestle with their own relationships with men and with their husbands and how they're viewed. One of the women said, "When I lost my second baby, my husband left me and said I'm no good." Another said, this was a nurse midwife in the group, "We help women who have lost a baby to clean themselves and become acceptable again for her husband." For many men, we think maybe it's a sign that the woman has cheated while pregnant. This was one of the men in the interview, pilot. And so there was this widespread stigma attached with not just stillbirth, by the way, but preterm birth. If you've had several preemies that don't survive, a lot of times as you know, a husband may trade you in for another model if you aren't able to have healthy babies, or if your babies are sick. So I think we have, you know, not a very good sense of again, we looked at the numbers on high, but there's this view from below of disease burden that's so critical, and I think it can operate as kind of a catalyst for change. We're looking at the cross-cultural beliefs as well, and it highly impacts reporting. If there's a lot of stigma associated with syphilis, for example, or with other infectious diseases, with having had a previous miscarriage, I think it's really important to know that and to know the context in which you're working to improve our epidemiology, so that we know what the disease burden actually is in an area. And I want to raise a somewhat provocative question in thinking about women's role in addressing neonatal mortality. And that is, I think, it's important to ask whether empowering women might not be better than surfactant. We know, and there's a lot of data to support, that social and political marginalization of women impacts demand significantly for prenatal and antenatal interventions. Across the board, literacy, education, and political empowerment, so being able to vote, for example, even in a local election, even unofficially having a powerful group of women who are very active in the village, can improve access to prenatal delivery and postnatal care. There's a Chinese proverb that recently inspired a really wonderful book by the same name, that women hold up half the sky. And I think they hold up a lot more. And so one of the things to think about in thinking about addressing the issues and the dilemmas that we face, both as individual providers, but also at the policy level, when you back away and think about how do we make that better? How do we get rid of the what ifs? Is to think about a critical component of this, which is empowering women. It's valuable as an end in itself, obviously, for the women, but it's also critical as a catalyst for change, for neonatal survival, for the health of their families, and for the health of communities. And so I think as you move forward, it is possible to aim higher, to be aware of a standard of care that's much higher than where you are, that's very difficult to even approach. And I do think it is a kind of moral psychology that you carry with you when you have a foot in both worlds. And it carries with it, I think, a responsibility, which is to think about the advocacy piece when you walk away. I think these dilemmas are sentinel events, that when they happen, they're as senseless as the deaths, the hardship that they cause the families, but they're sentinel events. They're revealing unacceptable trade-offs that are simply at the root of a life in poverty. as Maneesh mentioned, the opportunities are right in front of us. We have very, very simple, inexpensive interventions, but we also have some really complex, deep solutions related to social and economic change and political change. And that's where a partnership between clinicians, healthcare providers, and politicians and development workers is so critical, having the right hand know what the left hand is doing. And this is what's in front of us. It's a really, really simple goal. What you're aiming higher to achieve is just happy women, healthy babies, happy families. It's a very, very basic sort of universal appeal. And so I know a lot of you wrestle with and have wrestled with very difficult, complicated, high-tech ethical dilemmas. This is a simple, simple ethical problem in a sense. To me, this is not gray at all. Thanks very much.
You've been watching speakers from the 2010 Pediatrics Bioethics Conference, Tiny Babies, Large Questions, Ethical Issues in Prenatal and Neonatal Care, presented by the Truman Katz Center for Pediatric Bioethics at Seattle Children's Hospital. For more information about this series of programs, please go to www.seattlechildrens.org/bioethics.
It just lets you put things in perspective. You want to take one step back to look at a total picture and not just the tiny baby you're taking care of.
Any kind of information we can get and share back with the staff helps to make us provide a better patient experience.
I'm actually okay with people coming to a conference like this and leaving with more questions than they started with. I think that's a good thing.